Hello, my name is J.D. Corll. I'm an interventional cardiologist at the Christ Hospital in Cincinnati, Ohio, where I serve as the Peripheral Vascular Disease and Critical Ischemia Program Medical Director. I appreciate the opportunity to present this very interesting CLI case. We have a 64-year-old male with Rutherford V peripheral artery disease, has a non-healing ulcer of his left foot with ischemic rest pain. His past medical history includes peripheral artery disease with critical ischemia, coronary artery disease with a history of bypass surgery, chronic systolic congestive heart failure, hypertension, hyperlipidemia, and diabetes. Patient is status post multiple interventions involving his left SFA and popliteal artery. These interventions started back in 2003. In July of 2005, Viabond covered stents were used. More Viabond covered stents were used in January of 2006. In April of 2006, a fem-pop bypass surgery was performed. In July of 2007, that graft was noted to be occluded. The following day, there was an attempt to revascularize the graft. That attempt was unsuccessful. Approximately 10 years later, in January of 2017, there was an unsuccessful attempt to revascularize his native left SFA and popliteal artery. The patient did develop the ulcer on his left foot and was ultimately referred to the Christ Hospital CLI program in October of 2017. Here's his non-invasive study showing occlusion of the left SFA, popliteal artery, TP trunk, peroneal artery with monophasic flow in the left AT and PT. The left fem-pop bypass graft was occluded. Here's the angiogram of his left iliac system showing normal flow and widely patent stents. Here's an angiogram showing his left common femoral artery with occlusion of the fem-pop bypass graft and occlusion of the left SFA. Here you see a long segment of stents extending from the left SFA into the popliteal artery. Here's the angiogram through that section showing collaterals. Here's the angiogram of the left tibial vessels. This is very delayed filling via collaterals. The left foot also has very delayed and slow filling. We elected to perform triple access on this case in the right common femoral artery, the left anterior tibial artery, and in the left SFA within the previously deployed self-expanding stents. On the left, you can see the left AT access. On the right, you can see the fluoro guidance to access the proximal stent in that left SFA. This is above the Viabond stents in the SFA. We put a 6 French sheath in the SFA, took the wire up to the common femoral artery. We then used an outback device to re-enter into that common femoral artery. The wire was snared with a gooseneck snare and externalized through that destination sheath. The wire was then reversed. The distal tip was then pulled back into the mid-left SFA. The SFA sheath was removed and the wire was advanced down through the previously deployed stents to the mid-popliteal artery. We also advanced a guide wire up from the AT access into that left popliteal artery. We tried some cart and reverse cart techniques to try to get the wires into the same plane, but ultimately we used the outback device to puncture an inflated balloon in that popliteal artery. We then pulled the wire through that anterior tibial sheath and externalized the wire. At this point, we performed multiple laser atherectomy runs in that left SFA and popliteal artery, followed by balloon angioplasty. We also extended the balloon angioplasty down in the left anterior tibial artery, as well as into that TP trunk. Following multiple balloon angioplasties, we performed our final angiograms. Here you can see the flow in the proximal SFA. Here's the flow through the mid left SFA and flow down into the popliteal artery. And finally, the brisk direct flow into the tibial vessels. Patient did ultimately heal that ulcer, and I appreciate the opportunity to present this case. Thank you.